All right, it is 7:01. We'll go ahead and get started, and as more people join us, we'll let them in. Thank you so much, everyone, for joining us today. Uh, we'll ask that everyone just have their computer on mute if we can, and then we'll unmute as we discuss the topics. My name is Olutayo General Surgeon in the Acute Care and Trauma Department at St. Vincent's in Bridgeport, Connecticut. We're presenting today a Health Disparities in Medicine series. The topic will be breast cancer tonight. I was going to kind of open it up for a few words from Dr. Demestajas, who is the department chair and chair of the Health Disparities panel. Dr. Demestajas.
Hi, everybody. Thank you so much for all of us participating in this. A lot of discussions that need to continue to happen so that we are able to give everyone the equal care that they need. I thank all the panelists for participating at the end of an extremely long day for all of us. And I thank especially Whitney and all the other students who have done such a great job of putting everything together. And again, I apologize for the CME thing. We will get it one of these days working, but once I have the list, we'll upload everything and everyone will get credit. So thank you. And thank you, Dr. Segunro, for your commitment to this.
Thank you, Dr. D. So as you guys see here, we'll pass this slide just because the CME is not available at this time, but I do have attendance for everyone that was here. So we will be able to get that CME to you. At the end, we do have a survey. You can take a picture with your phone now and get it popped up on your phone. We'll have this QR code also available at the end of the lecture as well for you to just take a quick 2-minute survey to let us know what you think of our Health Disparities panel. So these are the discussions that we will be having. Health disparities affect minority populations and are an important aspect of public health. These discussions that we have been having and will continue to have are academic, social, and medical, and they're rooted in research as well as a clinical experience, which is based on this open forum that we have today. Our planning committee includes Dr. Anthony Demestajas, myself, Olutayo Segunro, Dr. Shauna Tile, Dr. Falade, Dr. Listy Thomas, Whitney Nichols, and Tatonia Douglas, who are MS2s at Quinnipiac University Netter School of Medicine. This is a joint effort between the Department of Surgery, of which I am a part of, and Dr. Demestajas is the chair at St. Vincent's Medical Center, the Department of Critical Care, the SNMA, the Clinical Arts and Sciences at Netter School of Medicine, the LMSA, and BINGAP. So I thank all of these organizations and us coming together to put this on for you today. When I is replaced with we, illness becomes wellness. So we'll talk about an article, well, 2 articles actually today, have a panel discussion and have an open Q&A at the end. Our panelists today are Dr. Bridget Killelea. She is our breast surgical oncologist at St. Vincent's Medical Center. She recently joined us and we're so happy to have her. She is an expert in the subject area and really is everything to her patients, and they love her, and we are very thrilled to have her today and to hear from her expertise and her experience. We also have Dr. Darian Showell. Dr. Darian Showell is a hematologist oncologist. He is someone who I've known for a very long time. I went to medical school with Dr. Showell, and he does a lot with his breast patients currently in the Midwest. And really, he has a unique perspective, and I'm excited for us to hear that today. Then we have Dr. Sandhya Danjal, who is one of our hematologists and oncologists at St. Vincent's Medical Center as well. She and I recently met, but we've had great discussions about the disparities that really affect women, and this is one of her passions, and it's just really great to have her on tonight. So thank you so much for joining us. And we also have Dr. Karen Masada. Dr. Masada, I'm sorry, is a surgical resident, but also a Netter School of Medicine alumni who really deals with a lot of inner city patients and has a lot of experience with these disparities, particularly with the patients that she's taking care of now. So it's really going to be great to have her experience as, you know, a new physician, a surgeon in training, and also someone who's working with a disparity-laden area. So thank you all to our panelists for being here today. Our student moderators, Madison Masters, she is a class of 2024. She is the current SNMA treasurer, and Valeria Saldana, she's also class of 2023, and she's LMSA vice president. These two young student doctors have been excellent. Just working with them, getting ready for this panel. They are very astute, bright young women, and the future of medicine is great with them in it. So at this point, I will go ahead and turn it over to our student moderators.
So before we get started, we wanted to acknowledge that some terminology that will be used tonight is not inclusive, but reflects terminology used in the research articles. We want to point out that the term woman, which is a chosen gender identity, should be assigned female at birth to be more inclusive and to reflect intersex, transgender, and non-binary patients. We encourage everyone to keep this viewpoint in mind during our discussion this evening and to take it with them beyond this series. So with that, I turn it over.
Thank you very much, Dr. Segunro, and thank you very much, Whitney. So this paper was Healthcare Disparities in Breast Cancer, the Economics of Access to Screening, Diagnosis, and Treatment. It was very interesting. The main points to take away from this were that the paper aimed to review the economic, cultural, and social injustice factors that may contribute to these disparities, particularly in breast cancer detection and mortality, by comparing the experiences of women in safety net hospitals to other sorts of academic or higher income hospitals, particularly in the context of Texas, where this paper was done. It was found that poverty, race, uninsured status, and a lower level of education are significantly associated with higher breast cancer mortality rates. That breast cancer patients treated in safety net hospitals face significant challenges due to presenting at a later stage and also not consistently receiving adjuvant treatments that have been shown to increase survival. While the incidence of breast cancer in non-Hispanic white women has stayed relatively steady for a while now, that in Black and Hispanic women has continued to increase. And I think a good conclusion would be that, from this paper, improving access to breast cancer care, increasing breast cancer screenings in underserved populations, and reducing the time from diagnosis to treatment are actionable ways to reduce these disparities. So, noting that Black and Hispanic women are more likely to be diagnosed with an aggressive triple negative or otherwise unfavorable breast cancer type than non-Hispanic white women, this adds a biological disadvantage to the socioeconomic ones that they face. So Dr. Donjel, do you think you could discuss the biological differences in breast cancer for minorities, especially regarding triple negative breast cancer? Do you think that this information does or should impact the way that preventative care is directed and managed for all different patient populations?
Hi, thank you for having me. First of all, we know that triple negative breast cancer is considered a very aggressive breast cancer. It's called triple negative because it's estrogen negative, progesterone negative, and HER2 negative. About 15 to 20% of breast cancers are triple negative, and we do tend to see them in younger African American patients. There are a lot of speculations and ideas of what the biological differences are in these patients and why they have a predilection to triple negative breast cancer. One thing in biologic factors could be, genetics. There are a lot of genetic associations for triple negative breast cancers, patients harboring BRCA genes or PALB2 genes, P10 mutations, P53 mutations, among others. Often, people don't know or are undiagnosed. Other biologic differences among our lower socioeconomic status patients, poor nutrition and obesity. ASCO has actually now endorsed obesity probably as a leading risk factor for cancer development, probably even ahead of smoking at this point. And having poor nutrition and cardiovascular risk factors at younger ages affects their susceptibility to cancer, i.e. by obesity causing increased insulin resistance and inflammatory mediators that are elevated in the body, causing carcinogenesis. So I think those are some of the biologic issues that we have that are adverse in this population that could promote cancer formation. Regarding how we should impact the way preventative care is directed, I think a lot needs to be done in terms of education. In my experience, there's a lot of doubt and sort of mistrust in the medical system, especially with cancer care, misunderstandings of chemotherapy, sort of a fear of having breast surgery, being disfigured. So there's a lot of issues that come into play, maybe with lack of understanding and education of handling this kind of cancer. I think we need to get screening mechanisms in place. I think endorsing self-breast exam is very important. We all, share patients together, Anthony and I for years, and have had patients who come in with a normal mammo one year, and then within that year develop a large tumor from one mammogram to another. So emphasizing the importance even of just self-breast exam. And then the last thing I wanted to point out is a lot of, medical societies, there's different guidelines from different societies, whether you look at internal medicine, surgical, radiology, oncology. So the oncology, American Society of Clinical Oncology, American Cancer Society, Susan B. Komen Foundation, we tend to recommend discussing screening starting at the age of 40, which I think would be beneficial for African-American young women. Some societies like US preventative task forces tend to lean towards the age of 50, and maybe even every other year cancer mammographic screening. But I think, talking to younger women around the age of 40 and being able to offer that type of screening would help in detecting cases. And in addition to that, providing them navigation through the medical system. I've had a lot of patients who don't speak English or are afraid to enter the medical system. They're worried about bills they may have to pay. They don't understand how to apply for state. So I think having, nurse navigators and case managers and social workers to help them with that would help them to break into the system. Thank you.
Thank you very much for your answer, Dr. Jonto. So this paper also highlighted the differences between breast cancer outcome by comparing between both racial groups and between differently funded hospitals, with particular emphasis on hospitals in Dallas. Dr. Masada, as a resident physician in Philadelphia, would you be able to comment on the differences you've observed regarding this disparity as compared to the Northeast?
Sure. Thank you guys for having me. So the papers indeed highlighted the differences in outcome between racial groups in relation to breast cancer. Although we all know that the subpar outcome experienced by African American patients extend well beyond just breast cancer and envelops healthcare as a whole. Let me start by pointing out that according to the U.S. Census Bureau, Philadelphia County has 43.6% Black or African American as a population, compared to 13% in the overall U.S. And the median household income is only about $31,000. So Philadelphia is also known to be the fourth most segregated big city in the United States. So basically, if you divided the city by its neighborhoods, you would notice that people from a particular neighborhood are most likely to be from the same race, and implying a low neighborhood diversity index. And if these segregations did not exist in every major city, we wouldn't have like Chinatown, a Little Italy, and unfortunately the so-named ghettos. So my residency program has multiple hospitals through which we rotate. And two of our main hospitals are located 15 minutes from each other. One serves a predominantly African-American community, and the other one is located in the suburbs. And they are literally just 15 minutes apart from each other. But the experiences that the residents have at one hospital is so significantly different from the other hospital. At the hospital that serves more of the African-American community, I had unfortunately witnessed a couple instances where African-American women in their 50s would present with fungating breast masses, not inflammatory breast cancer. And although I don't remember all the exact pathology of the patients that are coming into mind, these are cancers that could have been picked up on a routine mammogram, and these women are waiting and coming in with just this huge masses that are now invading into the skin. And when you look at that, you wonder, why are they waiting so long to come in and such things. And I do want to touch upon that a little bit. So I also wanted to mention really quick that according to the papers, the mentioned lack of health insurance, education, poverty, and others as causes of why patients present late at such a late stage. And in comparison to the Northeast, I was a medical student in Connecticut, and I don't think at that time I had the experience to kind of decipher exactly everything that may have been going on in terms of the patient population that were presenting at the hospitals that we were seeing. But even when you take a look at the New Haven population, it is also 32% African American. And in such an area, although there could be Yale New Haven Hospital, which we would all know it's a well-founded hospital, I wouldn't be surprised to see um, in the neighborhoods surrounding Yale, uh, with the indigenous population and the socioeconomical disadvantages that could be there, that some patients still have poorer outcomes. And there is also a strong body of literature that implies that even when socioeconomic status has been corrected, African American women still have poor outcomes. If you think, for example, about Serena Williams dying almost during her postpartum period. And I unfortunately couldn't find a celebrity with breast cancer who was African American who had undergone through this. But the point is that whether or not the differences are pronounced because of differential funding in a hospital, I'm not certain. Surely, a hospital with less resources would have poor outcomes, but also I think that doctors treating patients in for example the two hospitals where I'm working, the doctors are the same, so the knowledge is the same. And I just wonder whether as healthcare providers we could maybe do something to bridge that gap a little bit more from our standpoint, instead of just blaming the fact that the hospital does not have enough money on these outcomes.
Thank you again very much for your comments, Dr. Masada. In a cohort study of women with primary cancer diagnosed between 2007 and 2016, there was a 9.1% decrease of late stage diagnoses across all races and ethnicities in states that accepted the Medicaid expansion after the Affordable Care Act, while there was still a 3% decrease for Black women. Dr. Killelea, why do you think this discrepancy exists for Black women, even after implementation of the ACA and Medicaid expansions?
Yeah, so thank you again for having me, not only tonight, but also for putting on such a really important and tremendous collection of topics and talks. I think this is really great work and really important for everyone to hear. I think a lot of the comments that have been made so far are spot on. I've been treating breast cancer patients for over a decade, both in New Haven and now in Bridgeport, which are both very diverse communities. We see a wide range of patients, and I think that really getting to a lot of these questions about disparities is incredibly complicated and intertwined. I completely agree with the comments that, we know that African American women do tend to present at later stages, but we also know that they have more aggressive disease that can be harder to treat. And I think that it's really a combination, both of these socioeconomic factors, as well as perhaps a genetic predisposition to more aggressive breast cancer, that combine to make this such a challenging disease to treat for so many African American women. I think getting specifically at this question about the discrepancy, after the Medicaid expansion really gets to an issue related to trust in the medical system and the ease of access for African American women getting in to see a doctor, getting an appointment, getting timely care. This also relates to issues around work, taking time off from work, even things related to transportation, getting into an office to see a doctor. You know, these may be things that many of us take for granted, but for a lot of the patients that we treat, these are significant barriers that can contribute to, I think, some of these disparities. In addition, I would also add that I believe Dr. Denjal brought up the issue of I have noticed in my career so far and in my practice a certain amount of distrust or difficulty sometimes blending recommendations that come from purely Western medicine and Western medicine-based recommendations for treatment with other cultural and even religious concerns and issues that some of our patients bring to the table. And I think that it is absolutely the responsibility of the doctor to listen, to take time with our patients, and to really explain why we're making the recommendations that we are, and work together with our patients to come up with a treatment plan that is acceptable for them.
Thank you very much, Dr. Killelea, for your comments. Really appreciate it.
Thank you so much, Dr. Killelea. Sorry to interrupt. Dr. Demesta-Haas, did you have a quick comment you wanted to make?
Yeah, I did want to make a quick comment. You know, this was something that we noticed in the Bridgeport area about 12, 13 years ago, which led to us really developing a breast specific service that did not exist before 2008. You know, and we're a very small group of physicians and nurses and other team members in the breast team. So I'd like to say that I think we have made a difference, small difference in our community in being able to build the trust. And it takes all baby steps that eventually lead to big giant steps. So I do think that it's really important that we all work together, and wherever you go to really identify the areas where you can make a small difference, and a small difference becomes a big difference eventually.
Great, thank you so much. I really appreciated that comment, Dr. Demesta-Haas. All right, and then on to the last question for this paper. So their paper noted that there are linkages between poor breast cancer prognosis and levels of education, although the mortality difference between non-Hispanic white women and Hispanic women was not statistically significant when adjusted for education. So Dr. Showell, could you please comment on your own experiences with patient education? How can physicians mediate this gap in patients' knowledge for the sake of their healthcare, particularly in the context of preventative care and screening?
So thank you for having me, and thank you for the invitation, Dr. Segunro. I tend to be a little wordy, so I won't talk too much, Tayo, I promise. But I do this job as a medical oncologist because of my own experiences. I often tell the story. Everyone asks, how did you end up being a cancer doctor, and why would you ever want to do that? And the reason I do this job is from my personal experience of having a sister who was diagnosed at age 12 with an osteosarcoma, and ended up passing away from a rhabdomyosarcoma, surprisingly, at the age of 22. And my sister passed away without ever having heard the word hospice from her doctor. And my family at the time, not being very medical, my parents were hard workers, high school educated people who just believed in raising their children right, and not knowing much else with medicine besides that. They did what the doctor told them. But as I progressed in my career, in education, and then recognizing that I wanted to do medicine, I kind of realized all the ways that medicine failed my family, and particularly the field of oncology, including medical oncology and radiation oncology and surgical oncology, failed my family, just from lack of education more than anything. It wasn't that I necessarily believed that my sister, would have lived if things would have been different, but it was more so my family would have been able to maybe deal with things a little bit differently had we been properly educated about my sister's disease and the disease process. There's no way that my sister should have been on a phase 1 clinical trial and never heard the word palliative care and never heard the words hospice. And so that is my fire, if you can't tell. That is the reason that I'm so passionate about patient education. And if nothing else, when a patient leaves my office, a patient, maybe sometimes overwhelmingly so, has more information than that with which they came with. So I believe that patient education is a major portion of a patient's care. And I do believe that while, as it's been mentioned here several times, there is a lack of trust and such strong mistrust with African American community and the medical community that does exist. I do think that much of that can be dispelled with education. Um, I think the onus of that education is on the medical community and the medical industrial complex in general, and should not be put onto the patient, which I think sometimes happens. That we say, oh, the patient, well, they don't know or they don't understand. Well, did you explain it to them at a level that they understand? And did you take the time, which often ends up being the failing of the medical system with patients? We don't have time. We're all busy. We have 25 patients, 30 patients a day that we need to see, and I don't have time to sit here and explain this to you. Well, that's that person's life and makes a big difference in perhaps the decisions that that patient may make regarding their care. So education becomes extremely important, even in the setting of preventative care and screenings. Um, Taking the time to explain to a patient the reason that preventative care and screenings are important, and the reason that perhaps African American patients should be screened at age 40 instead of waiting until 50 or sometimes even later, is important. That's a major part of what I do, and a major part of what I encourage everyone on this meeting to do is to make sure that you meet a patient where they are, in terms of education and understanding, and honestly learning how to read the room. Some physicians get into such a zone that when we are discussing medicine with the patient, I've witnessed it myself. Being in training in Charleston, which is 30% Black, and being in a room with an attending with a Black patient and seeing that patient's face and knowing they don't know what that attending is talking about. They have no idea. And having to circle back to the room and talk to that patient later in terms that they may understand. These are things that are important that we all can do that will help patients perhaps make better decisions for their care and maybe help bridge the gap in lack of education.
I completely agree. And I think just one thing that I think is so challenging in this arena in terms of preventive care for breast cancer screening. And, I really didn't fully grasp this concept until I started seeing it, was this idea of interval cancers, which means that, sometimes particularly aggressive triple negative breast cancers can grow so quickly that we miss them from one annual mammogram to another. And so I think I would just add that for me, a big part of patient education is teaching patients and explaining the importance of breast self-exam and not being afraid or feeling like they're bothering us to come in to check a lump or to accept patients from referring providers when they just want somebody else who's used to doing clinical breast exams to check something, because we do know this happens. And sometimes even with imaging, there can be, what we call mammographically occult or ultrasound occult breast cancer. So we really do have to, be on our guard and help patients understand that this can happen.
Absolutely. Thank you so much, Dr. Showell, and thank you, Dr. Killelea, for jumping in too. So thanks to all of our panelists. This concludes this particular paper, and I'd like to turn it over to my colleague, Valeria Saldana, for the next one.
Thank you, Madison. So the next paper is titled Disparities in Breast Cancer Stage at Diagnosis of Race, Poverty, and Age. And so some key points from this paper. So the paper aimed to evaluate the association of race, age, and census tract area poverty on breast cancer stage at diagnosis. So the study was limited to women in Missouri. However, it was a really large scale study, and it was a really well-powered study with tangible data and externally valid conclusions to other communities in the United States. So even though another point that the study concluded was that even though the number of breast cancer cases was higher in white women than in Black women, the risk of advanced stage presentation was greater among Black women. There was a 30% increase in chances of reporting late stage breast cancer among Black women relative to white women. There was about a 14% increase in the chances of reporting late stage disease among women living in extreme poverty level census tract areas compared to women living in low poverty areas. In the 18 to 39 age group, the odds of a late stage presentation among Black women tended to be greater than in white women and higher relative to women aged 50 years and older. And the overall conclusion was that this study revealed that stage of breast cancer diagnosis was associated with race, age, and census tract area poverty level for all of the participants. So for the first question, so this study and other studies have exemplified the widening disparity gap in overall cancer diagnosis and survival between Black and white individuals in the US. Dr. Danjwal and Dr. Showell, do you believe socioeconomic status plays a role in breast cancer diagnosis? What role does advocacy for equitable access to screening and insurance coverage play?
So I guess I can start. I mean, I definitely think socioeconomic status does play a role, especially in their advanced stage presentation. I think it's, again, lack of access. A lot of things we touched on already, having the ability to get into the medical system, traveling further distances, maybe not having access to good care in their neighborhood, the fear factor issues. I think how we can improve this and have better access and insurance coverage is, again, offering, things like mobile mammography units, what we did at St. Vincent's. We have Swim Across the Sound funding through St. Vincent's as well, which helps our cancer patients with bills and payments to help them cover their cancer care. And I think having advocates in the medical system, so not only an oncologist and a surgical oncologist and a radiation oncologist, but also having, like I said before, whether it be a lay navigator, a nurse navigator, case manager, social worker, to help with extra time and education for patients to help them navigate through the complexities of the medical system, applying for health coverage and other things as well.
So that was going to be actually my big addition to that portion of the conversation. Really was very much helping these patients learn to navigate the system. It is for someone who is not medical, it is terrifying to learn to navigate the world of oncology. And that's even so much as knowing the difference in a medical, surgical, and radiation oncologist. Patients don't know these things. And if there are systems that are not in place to kind of help them learn these things and navigate these situations, they're often lost. Even when it comes to doing things like getting, for instance, getting their first mammogram and having a follow-up mammogram being scheduled appropriately, those things are all kind of lost in translation for patients who don't understand the system. I currently am in Madison, Wisconsin. which actually has a very small African American population, only 7%. But the private hospital that I work for, as far as the medical oncology department, literally has one nurse navigator for the entire department. Um, and that is very similar to the system that is in Milwaukee, Wisconsin, which is 50% Black, where they don't have the systems in place to really help these patients learn to navigate the system. Patients that need time off of work and think that, you know, they can't undergo cancer treatment because they have to work, they have children to support and families to support, and these are things that are often kind of not going to be addressed. We don't have time to address them in the exam room. And so having a social worker or having a nurse navigator there to help these women understand that they can get their cancer treated and continue to support their families at the same time is paramount. It's absolutely major in their care. And I think that's a place that sometimes we falter in medicine.
I think, and I have to agree with you. I feel like they have so much on their shoulders compared to, you know, from one patient to another. A lot of these patients have so much that they're weighing in on, that we come in and we think about our medical issue, like what am I going to give them for chemotherapy, and they're going to need radiation, and they need a lumpectomy or a mastectomy, and we have all these other issues that come up, and it becomes extremely overwhelming for the patient. I've had patients show me their paperwork on how do I apply for state or what do I do, and I look at their paperwork and I say, I wouldn't even be able to do this if it was for myself. So I completely agree.
And I do, if to add one more thing, I'm sorry, Valeria, just to add one more thing. This is also again where patient education comes into things. One of the grand rounds that I went to as a fellow in Charleston was actually given by one of the plastic surgery residents, who was the only Black and the only female plastic surgery resident that was there, and she actually gave a talk on the disparities in breast reconstruction when it comes to plastic surgery, which it's major. African American women not only don't get reconstruction as often as white women, but they're not offered reconstruction as often as white women. And so these are areas where, you know, it's did the surgeon take time to sit with this patient and explain to them? You know, I know someone had mentioned earlier about there being fear of getting surgery and disfiguration. I think it was Dr. Dunjal, but you know, fear of being disfigured after surgery. Well, did the surgeon take the time to sit with that patient and explain to them that there is the possibility of reconstruction? And so these are areas where I think, again, education will help. While socioeconomic status does play a major role, education.
Thank you, doctors. So the next question is, this study and other studies have exemplified the widening disparity gap in overall cancer diagnosis and survival between Black and white individuals in the US. Dr. Kidderly and Dr. Masada, in what ways can current and future physicians help narrow this gap?
So I guess I'll go first. So I think this is really, you know, a question that despite so much research and not enough attention, but you know, thankfully, I think right now a renewed attention, we really don't know why these survival differences persist. You know, like I mentioned before, I do think that it's a complicated question, but I think this is really a question that the future generation of doctors, you all who are so amazingly engaged tonight, need to help us figure out how to answer. So, for example, a few years ago, I looked at something called the National Cancer Database, which is a large national repository of data. And I've always been interested in disparities in breast cancer treatment. And we looked at differences in what we call pathologic complete response, or we call it PCR for short, for women who got neoadjuvant chemotherapy or chemotherapy before surgery. And what we found was that when we matched patients, for stage and other factors, African American women, even when we controlled for triple negative subtype or HER2 positive subtype, didn't respond as well in terms of the PCR rate as white women. So we have to continue to study these questions. We have to be curious. We have to ask new questions, and we have to really talk about our findings and publish our data and hold forums like these where we keep each other informed and we all continue to work on these issues together.
So I think I have a little bit of a longer answer as well for this question. Um, Let me start by saying that, trying to find a solution to this problem definitely starts with the next group of physicians that are upcoming as well. Let me start by making a personal anecdote. So perhaps you may have heard that I have an accent. I immigrated to the US when I was 17 years old. And I remember after I turned 18 or so, my Medicaid was revoked. And I remember just falling sick during one winter. And the reason why I was sick was because in our apartment at that time, I was sleeping near the door on this hardwood kind of structure and right underneath the heater, and I just got sick. In order for us to get to where I needed care at, we needed to wake up like at least by 5 a.m. in the morning, get on the bus, make it there. The community center or mobile med that we utilized at the time only had a certain days during which the patients could be seen. So once you get there, you have to hope that you put your name on the list and you wait along and hoping you would have made the cut that day, basically. Thankfully, I was seen. I was asked just a couple questions, whether I were homeless, did I have food to eat, and a couple things about my symptoms. And then somebody just gave me a pill or pills to take. Of course, I took the pills, we went home, and I just left them on the table. Because during that interaction, first, I didn't know what I had. I didn't know what pills were being given to me. I did not understand anything about what was going on about my own health. And I remember over the next week, I deteriorated so much I couldn't walk anymore. And at that time, my mom contacted one of her coworkers who was a nurse in the Philippines before, who came in and saw me and said, well, your daughter has pneumonia. And she needs antibiotics. What pills did they give you when you went to the clinic? And she showed her and she said, you know what? I think you should take these pills. They will help you. And in addition, she taught us how to have like supportive care and all that. When I'm in a doctor's office now, or even before I entered medicine, and I guess my plea to the new physicians coming in is when there is an African American person in your office, an African American woman from a low socioeconomic background, like we had zero money. We want, or we're hoping that you look at us as humans, basically. And sometimes it is hard. I think perhaps the doctors do want to do it, but there's so many statistics associated with our race already, with our outcomes already. And I think a lot of the time we miss perhaps that warmth that we would have gotten if we weren't Black and if we weren't women. Now, in terms of solutions to bridging the gap, there is an overuse of emergency department as a source of primary care by many patients with low socioeconomic backgrounds. Perhaps they don't know how to get a primary care physician, but that itself puts them behind in so many ways because one, you don't have an ally in the community that's ordering these mammograms for you and checking your milestones and the your age and making sure that you're doing all the screening tests you need to do. And a lot of all the panelists touched upon so many things, including patient education. You know, patient education is so important to establish trust with your patients. Because can you imagine that now thinking about it, me just not taking a simple medication because I was not educated on that. And I wasted away so quickly that perhaps if I was older, maybe I would have passed from this. I don't know, but how important it is for you to just explain to the patients what it is exactly you're doing for them. And Dr. Denjal also mentioned the lack of access. You know, I just remember being on a bus at 5 a.m. in the morning and maybe taking multiple buses just to get to where you're going. My mom having to take off work just to take me. That's lost income. All those things that the patients have to go through just to show up at your office for them can already be tremendous. Lack of insurance, access to good care, all mentioned by Dr. Denjal already. Now, sometimes when the patients are in our office and we're explaining or we're trying to get them to understand what's going on with them, I like this analogy of when we take our cars, for example, to the mechanic and the mechanic says your transmission is down. Do we really know what part of the car is the transmission and what its role is in the functioning of our car? When you're telling somebody they have cancer and they have cancer in their breast, and you're hoping that they grasp that concept, are they really understanding what it is you're explaining to them? A lot of the times, I can tell you that, you know, based on just personal experience and my experience of perhaps when an attending walks away after explaining something to a patient, and I just look at them and I ask them, like, would you want me to go over this with you again? You know, and me just being there and spending the time and having them understand exactly what it is, because I know when they understand, they're more likely to stick with the treatment plan. And basically, the last thing I wanted to add was that doctors treating a particular community need to perhaps have an open mind and have to be invested in that particular community for things to change. It's already a lot, I know, asking on physicians who have a mountain of patients to see, a mountain of paperwork to do. But the difference between your patient leaving your office and coming back for a follow-up appointment and following the treatment plan is just maybe a 2-minute explanation in plain language on what it is that's going on with them, and putting the importance of their health now is also going to be their family's prosperity, because a lot of the time when those patients are in those situations, taking off work to be in that office, lost income, how are they going to pay their bills or feed their kids, is already, you know, such a great stress on them. So I just hope that next time any of my colleagues have somebody who is considered low socioeconomic, African American woman, I hope that they remember that, perhaps they remember my face as in these women as well, and perhaps start taking the time to explain to them the things that they really want them to understand.
Thank you so much, Dr. Kiley and Dr. Masato, for your comments. So some take-home points from both articles. To improve access to breast cancer care, we need effective and programmatic strategies to reach areas and populations most vulnerable to advanced stage breast cancer diagnosis. The following are actionable suggestions. 1, increase breast cancer screenings in underserved populations. 2, reduce the time from diagnosis to treatment. And 3, advocate for widespread adoption of federally funded Medicaid programs that target underserved populations. And next, I'd like to turn it over to my colleague, Whitney Nichols.
Okay, great. So I want to thank all of our panelists for your discussion points. I did want to open up to everyone in the chat for questions. I do have one question by Stephanie that I'd like to read at this time. So Stephanie has a question regarding Dr. Dandrell's first point in the talk. Is the issue that Black people have a genetic predilection to TNBC, as in there's some inherently biological about it? If so, is there literature definitely saying this, or that they and other minority groups are underrepresented in breast cancer genetic databases and are not represented or offered genetic testing or certain interventions for breast cancer at equitable rates, even when controlling for insurance and other socioeconomic status factors? To open up to anyone on the panel.
I can answer that a little bit. So there have been studies looking at this question, and there's a researcher, and her name is Lisa Newman. She's a breast cancer surgeon, and she has done a lot of work, even traveling to West Africa to treat patients and to gather samples. But there does look like that there is an association between West African ancestry and a predisposition toward triple negative breast cancer. So I would encourage, if you do, if there are students or others on this Zoom that are interested in this really interesting topic, you can just do a PubMed search of Lisa Newman, and that's a good place to start. She has some very interesting papers and research on this topic.
Yes, and that's a very good point. And I think with genetics and cancer in general, it's an evolving field. And I think our genetic bank is growing with different genes that we're testing for. And I think as comprehensive cancer centers are coming up, we are having more developed genetic screening programs with pre and post test counseling. And right now, at least our guidelines are for all triple negative breast cancers that we are offering genetic screening and testing.
If I can just kind of jump into that real quick about that question. So my alma mater, one of their campuses does a lot of breast cancer health disparities research. And one of the areas that they've been looking at in women, African-American women with breast cancer, not specifically to triple negative, but breast cancer in general, they've actually been looking, doing some genomic studies to look at glutathione, and they found that glutathione has been down-regulated in African Americans through several genes compared to women of Caucasian descent, and that is proposed to play a role in free radical development and therefore the development of breast cancer. So that's one of the studies currently going on, but definitely, like Dr. Killelea and Dr. Dandrell said, there are some genetic predispositions in a lot of different areas that are being looked at, and one of them happens to be with free radical production and glutathione.
Thank you so much for everyone for answering that question. The next question is a question that I posed. So there's been a call to abolish race-based medicine, which seems to be prevalent in decision-making, and according to the articles, it seems to also be prevalent in breast cancer. Is it possible that this push will help narrow some of the gaps in identification and treatment of breast cancer in Black people?
So I think that's a very tough question to answer, because eliminating race-based medicine would also put everybody in one basket. And like we have just mentioned with the discussion we had, unfortunately, sometimes there are some genetic differences in the races that need to be accounted for. So, I think it is, there perhaps needs to be a medium where, yes, we are trying to treat our patients the same and equally, but I think sometimes we need to keep in mind that depending on what race you are at greater risk for certain things, for example, the Ashkenazi Jews and the BRCAs. So unfortunately, we need to have that in mind, those race differences, to be able to provide good care.
I totally agree, and that was going to be really my take on that question, is that you can treat patients the same without having to ignore the differences in patients. Um, it's very frequent that you hear people say the phrase, "I'm colorblind and I don't see race." And that's something that I don't think necessarily works terribly well in medicine. I don't think it works terribly necessarily well in society either, but that's not why we're here. In medicine, I don't think that works necessarily well, because that causes us to really ignore these differences in patients that may make patient care difficult for people who are African American. It may be part of the reason that a doctor didn't take the extra time to discuss with Dr. Masada what she was being given as a medication and why she was given that medication, and what was really wrong with her. These are things that I think can be recognized, and the differences in people in general can be recognized without changing the care that's offered to patients. That I think that those things are mutually exclusive. I think that we can do both. So that's my take.
I think I agree with that. And I think that everybody from different backgrounds and different nationalities brings something different to the table. Growing up and studying in New York, I learned a lot about different people, learning about even different Hispanic communities, learning to speak Spanish. It's all helped and enhanced, communication and effective care for patients. So I think understanding and embracing different cultures and backgrounds helps to provide better care.
Thank you so much for answering those questions. So it looks like we're right at the 2 minutes. We have 2 minutes left. I know I did have a follow-up question, but I know that I wanted to be respectful of everybody's time. So I'll turn it over to Dr. Segunro to welcome to close us out.
Thank you so much, Whitney. Thank you to all our panelists who joined us today. Thank you to everyone who joined us in the audience to listen to this panel discussion. There were some really great questions in the chat. So what we'll do, Whitney, if you don't mind, we'll just copy and paste them out of them. Maybe we'll just email them to the panelists and we'll get them answered. And what we can do is just send them all back to everyone. I've gotten an attendance of everyone, so that way those questions are great questions and they can be answered on a later at a later time. Again, thank you everyone so much for joining us today. Our next panel discussion will be on the 31st. It'll be on colon cancer health disparities. We would love to see you there. We'll send you the link and the information. Dr. Danjal, Dr. Killaley, Dr. Showell, Dr. Masada, our great appreciation to you for joining us today. Really great, candid, and informative responses. I think, I definitely took away a lot of points from you all today. I hope a lot of people in the audience did as well. To Madison and Valeria and to Whitney, thank you so much. These are our future physicians, right? These are medical students who may or may not have a test later this week that are taking the time out of their day to be a part of this panel. And I'm really excited about the future of medicine, because these are the people that are going to be there. Like Dr. Killaley said, the young, I guess I'm not that old, so I'll include myself there maybe in that range. The future of medicine is really in our hands. And I just really thank everyone for joining us today, because we care, right? We're participating in these discussions because we want to make a difference and we want to take something from it and be able to improve our patient care and our patient outcomes. So again, thank you everyone so much. Have a great night. This link that you see, or this QR code, please, again, just take a picture of it and please fill out our brief survey for us today. And thank you. I can't say it enough. Thank you so much.